This video is sponsored by Med Exam Pass, your ultimate hub for medical exam success. We've just added the complete 2025 MRCS Part A recalls with detailed solutions alongside dedicated courses for FCPS, MRCP, and MRCEM. Experience our latest exam-centric question bank through an extremely user-friendly UI, all at an unbeatable price. Boost your prep today. Check the link in the description for full access.
Question number 16, tricuspid valve closure. So the correct answer should be the isovolumetric contraction. Number 2, let's submit the answer. And this is the correct answer. The description has been given here. So the tricuspid valve and the mitral valve, both are the atrioventricular valves, close at the beginning of the systole. So which marks the end of the diastole and initiates isovolumetric contraction phase of the ventricle. So during this phase, ventricular pressure rises rapidly, but no blood is ejected because both the atrioventricular valve and semilunar valve are shut down. Once ventricular pressure exceeds aortic and pulmonary artery pressure, the semilunar valve opens and ejection begins. Now, when the option B, the isovolumetric relaxations, would be the right answer. So let's say a 65-year-old man, an old patient comes with acute MI, has experienced aortic valve closure. The second heart sound S2. Immediately after the closure, ventricular pressure falls rapidly while both the aortic and the mitral valve remain closed. This describes the isovolumetric relaxation, the early diastolic phase where the ventricular volume remains constant but the pressure drops until it falls below the atrial pressure, allowing the mitral valve to open. So the difference between the isovolumetric contraction and relaxation has been, I think now is clear. Question number 17. The patients with recurrent bulbar palsy with a history of stroke for 3 days, which is the best management, what to do now? Now, the best possible way is to the tracheostomy with cuff. Now, let's submit the answer. And yes, this is the correct answer. Now, the recurrent bulbar palsy results in impaired cranial nerve function, cranial nerve 9, 10, 11, 12, leading to poor cough and swallow reflex. This puts the patient at very high risk of aspiration pneumonia. A cuffed tracheostomy provides the most definitive and protected airway management, allowing the effective ventilation where the inflated cuff prevents aspiration of oral and gastric content into the lungs. Now, when the NG tube would be the correct answer, the first options. Let's say an elderly patient presented with acute stroke but intake gag and swallow reflex. Gag and swallow reflex is intake, who passes a bedside swallow assessment showing no aspiration risk. So needed only short-term nutritional support. In that time, NG tube is the best option. Now, when the TP and total parenteral nutrition could be. So a patient with severe short bowel syndrome after massive intestinal resection, now patient is unable to absorb nutrients entirely. Orally, he cannot take the proper nutritions but has a protected airway and narrow swallow function. Now, in that cases, total parenteral or TPN is indicated for long-term nutritional support when the GI tract cannot be used. Next question. Question number 18. Female patient is being operated for femoral hernia. Bleeding started. Which structures from lateral wall of the femoral canal? So lateral wall of the femoral canal is the femoral vein is the right answer. So let's say submit answer. Yes. Now the femoral canal is a small space medial to the femoral vein within the femoral sheath. The anatomical structures medially lies a lacunar ligament. Lateral wall is formed by the femoral vein, anterior wall by inguinal ligament, and posterior wall for pectineal ligament, or in short, Cooper's ligament. Keep that in mind, pectineal ligament and Cooper's ligament are the same. And plus, along with these two structures, a pectineus muscle. Now, femoral vein lies lateral to the femoral canal and medially to the femoral artery. During the femoral hernia repair, injury to the femoral vein is recognized complications due to its proximity as the lateral boundary. So let's say I have a question like a young patient sustains a penetrating stab injury just below the inguinal ligament and presents with an expanding, pulsating, growing hematoma, absent distal pulse, no femoral pulse or the digital pulse are absent. Now, the primary injury structure, if the question asks what is the primary injury structure here, definitely that would be the femoral artery, not the femoral canal anatomy is needed here, just the artery, simple artery injury here in that scenario. Okay, next questions. Question number 9. Patient has a gastric bypass 2 years ago and surgery is planned after 4 weeks. Hemoglobin now is 9. Now, what should be the given? So, post-gastric bypass anemia before the surgery. So, correct answer should be we should give IV iron. We should give what? We should give the IV iron. Now, anemia after gastric surgery is commonly due to iron malabsorption, as the duodenum and the proximal duodenum, the primary site for the iron absorption are bypassed. So, with surgery planned, is only 4 weeks and significant anemia, hemoglobin is 9, intravenous iron is superior to the oral supplement for rapid corrections of iron supplements and repletions of iron stores. Oral iron has poor absorption post-bypass and may not adequately correct anemia in the available timeline. Now, when the oral iron should be the correct answer? Let's say an young female with heavy menstruation bleeding comes to us with normal GI anatomy. Now his elective surgery is planned months after, 3-4 months after for now. So that is the scenario with that we can give the ferrous sulfate iron supplement will be the first line of treatment with intact absorptional capacity and adequate time for the corrections. Now, vitamin B12, you might argue with this one, but let's say if a 5 years post total gastrectomy, it's a patient with total gastrectomy, patient with fatigue, glossitis, and macrocytic anemia, and laboratory test found low serum B12, elevated elevated methyl malonic acid, very important key point. Normal ferritin iron profile is good. Now that in that case diagnosis is a B12 deficiency due to lack of intrinsic factor. Parenteral B12, hydroxycobalamin, B12 has another name, keep that in mind, hydroxycobalamin or sialocobalamin. Injection is the key treatment, not the iron in that case. So next questions, PPV. So positive predictive value is related to which positive predictive value deals with which test characteristics. It is the sensitivity. Just now, let's give a very short explanation. The positive predictive value is the probability that a person who tested positive truly has the disease, and positive predictive value directly influenced by the three factors. PPV is direct influenced by the three factors. One is sensitivity, specificity, and disease prevalence. These three factors are very much influence the PPV. So while sensitivity and specificity reflect the test intrinsic accuracy, positive predictive value increases as the disease prevalence rise. So let's say we have this, a patient came, we have a VDRL test has been positive. Let's say in that culture, in that society, the disease prevalence is very low. Let's say 1 out of 1 million patient has extramarital affairs, so they have the VDRL scenario. So if the patient has been positive, it is very unlikely that he has the really VDRL positive. So, and in another scenario, while let's say in the Western culture where in Denmark or Amsterdam or any other Western culture where, or in the Thailand where the prevalence STD is very high. So in that scenario, if a patient is positive, then patient is likely to have the disease. So the disease prevalence, the society, how much the patients is there in the prevalence rate of the disease in that society also directly influence the positive predictive value here. Now, specificity is defined as the true negative point, and a negative predictive value when a patient is become VDRL negative, how truly he or she has not the disease, that is the negative predictive value, but that's a different question. For now, let's start with the positive predictive value. Sensitivity is the most specific thing here. Now, question number 21. Coronary artery auto-regulate its flow. I mean, it's increased in high heart rate. So, coronary auto-regulation is high rate. What would be the correct answer or scenario physiological could be? So, in here, if the blood volume has raised, that would be in diastolic pressure. Increase in diastolic pressure. Let's submit the answer here. Yes, this is the correct answer. The explanation here is coronary blood flow occurs predominantly during diastole. At high heart rates, diastole time becomes short, so which could compromise coronary perfusion. However, coronary autoregulation maintains adequate flow through the increased perfusion pressure during the shortened diastolic period. Increased left ventricular diastolic pressure helps maintain coronary perfusion pressure gradient in that setting, so ensuring continued myocardial oxygen delivery despite tachycardia. Now, you may ask why the second option, increase in diastolic volume, will be relevant. So let's say in uncontrolled severe hypertension, left ventricular afterload rises significantly, so resulting in increase in systolic pressure, very high in systolic pressure, that an elevated wall stress. So a question when it focuses especially on increase afterload and its hemodynamic consequence, then with this option B, increase in systolic pressure could be the answer. Now, question number 22. 12-year-old child presented with sudden onset of testicular pain. On examination, left-sided testis was elevated with horizontal line. What is the appropriate management? So, it is a scenario of testicular torsion. So, the correct answer will be bilateral exploration and fixations. So, this is the correct answer. The explanation here, testicular torsion means sudden onset severe unilateral scrotal pain, elevated testis, horizontal line, abnormal orientation, and high riding testing examinations. So the best possible management is in surgical emergency, bilateral exploration and fixation or chiropractic is a mandatory because the underlying anatomical abnormality, the bell clapper deformity, that means inadequate fixation of the tunica vaginalis. So but that is usually bilateral. Even though only one testis has torted, the contralateral testis is at high risk and must be prophylactically fixed. That is the most important. Even the clinically patient presented with one testis during surgery, we have to fix the positions of the contralateral testis too. Okay, to prevent future torsions. So this is very, very important. So in case where the unilateral exploration is needed, do we always have to explore the bilaterally? No. In adult man who sustained a direct blunt trauma, he has torsion, but that torsion is due to trauma. In that scenario, we will be unilateral exploration. Patient was not supposed to, no congenital abnormality, tunica vaginalis, or no chance of bell clapper deformity, only due to traumatic patient, one testis has been disrupted or torsion. In that scenario, only we will do unilateral exploration, not the bilateral. In this scenario, it is a younger children, so bell clapper deformity, we have to do the bilateral orchidopexy. Question 23. A 70-year-old patient undergoes repair of an abdominal aortic aneurysm. Postoperatively, he develops elevated serum potassium, almost 5, and low urine output and rising serum creatinine. Which of the following is the most appropriate next step? So, abdominal aortic surgery, post-repair, acute kidney injury, AKI. So to mass-based aptitude, patient is bleeding. So abdominal compartment pressure is very high. So what we have to do? We have to do the abdominal compartment measurement, this ones. So description has been given here. So this is particularly a post-abdominal aortic aneurysm. If the elevated intra-abdominal pressure become very high, more than 20, impaired renal, it causes impaired renal perfusion, renal vein compression, so creatinine become very high, oliguria or acute kidney injury, rising creatinine, elevated potassium due to decrease renal clearance, all are supportive of abdominal compartment pressure. So best to do measuring abdominal compartment pressure. How? Via bladder catheter manometry. Bladder catheter manometry is critical to confirm the diagnosis and guide urgent decompressive laparotomy if indicated. So other options addresses symptoms but miss the underlying surgical emergency. When we do the dialysis, so let's say when the potassium is more than 7 and if severe metabolic acidosis 7.1 or pulmonary edema unresponsive to diuretics, ECG changes showing very high tall PT waves, and then the abdominal compartment pressure is normal. So in that cases, urgent hemodialysis would be the indicated. Fluid will be given when? So postoperative patient, low urine output, hypotension, and inferior vena cava and flat inferior vena cava. I mean hypovolemic shock patient is this. Then we give the fluid corrections. When we give the renal ultrasound, post pelvic surgery, patient develops sudden complete anuria with subtle creatinine raises. Creatinine level is not so high, no abnormal distension, only sudden anuria. So that means renal ultrasound is essential to rule out any bilateral ureteric obstruction or ligation. That could be a surgical complication post-pelvic surgery. Then renal ultrasound will be the best option. When we give insulin and glucose because of the potassium level, right? So patient with diabetic ketoacidosis or hemolysis syndrome presented with potassium less than more than 6.5, and ECG shows tall T waves and widened QRS complex. Then the insulin with dextrose, 10 units regular insulin in 50 ml dextrose aqua, that is acute and life-saving therapy to drive potassium intracellularly, which drives the potassium inside the cell within half an hour. That's very insulin with dextrose in that scenario. So the clinical diagnosis would be diabetic ketoacidosis. Now question number 24. Patient had head trauma due to road traffic accident. So what is the least likely measure to decrease intracranial tensions? So hypothermia is the things. Let's put the answer here. This is the correct answer. Now, what standard measures to reduce the intracranial pressure head trauma? First, elevate the head 15 to 30 degree, then adequate analgesia and sedation, which reduces the metabolic demand. Now 3% hypertonic solution and mild hypocapnia due to control via control hyperventilation. Hypocapnia via control hyperventilation that causes the cerebral vasoconstrictions. So therapeutic hypothermia, 32 to 34 degree, 32 to 34 is a therapeutic hypothermia, is not routinely used in traumatic brain injury. While it is theoretically reduces cerebral metabolism, but clinical trials have not demonstrated clear benefits. So it carries risks occurring the coagulopathy, infection and arrhythmia, and others options are given here, which are well established management. Head A, C, D, all are the established management protocol of reducing intracranial tension, except the second one, hypothermia. Okay. Number 25, a 65-year-old man presents with a non-tender swelling in the right hemiscrotum. So at operation, the hydrocele sac is opened and 40 ml of fluid is drained. Now, which anatomical structure surrounds the fluid? So it's a hydrocele anatomy. What's the tunica vaginalis? Tunica vaginalis where? This one. Oh, sorry, the last options. Tunica vaginalis. I missed the one. Tunica vaginalis. Number 50 is the right options here. So we know the hydrocele collection within the tunic is a double layer serous membrane surrounding the testis. So it has visceral layer, parietal layer, and potential space between them. So visceral layer is added to the testis and epididymis, and parietal layer is the inner scrotal wall. In between two is the fluid where fluid can be collected. Now the fluid is directly surrounded by the tunica vaginalis layer, but not by the dartos muscle. So dartos muscle is subcutaneous scrotal muscle, or the tunica albuginea. Tunica albuginea is called testicular capsule. Albuginea is called testicular capsule. Okay. Next question. 26. Child sitting on bicycle Handle got injury after fall and presented with bruising 2 centimeter above the umbilicus. He is tachycardic and hypotensive. Most likely injury to which organ? So spleen is the first thing that comes to our head, but let's say there is no option of a spleen here. If there is no option of a spleen here, the best possible answer, left lobe of the liver. Pancreas is given here. So let's say three structures. The pancreas, the left lobe is the correct answer here. First of all, because liver lies very much in front of it. So the mechanism of handlebar injury is located 2 centimeter above the umbilicus, corresponding anatomy to the left lobe of the liver. So which extend across the midline to the left upper quadrant. So three structures most commonly, especially let's say liver lacellation, number one. Number two is the duodenum or the duodenal perforation, and the final is the pancreatic injury, which is very much less common but it still happens. Pancreatic also common, but the best possible option is the left lobe of the liver is the most likely the anatomical location impacted. Now, when the pancreas, I would give the answer. Let's say same patient 10 years old hits the central upper abdomen, the epigastric region, and he presents 12 hours later with persistent epigastric pain radiating to back with nausea, vomiting, serum amylase is very high. CT abdomen shows pancreatic transections on the neck of the pancreas and recognize delayed presentations of a blunt pancreatic injury. In case of transverse colon, there will be pneumoperitoneum, perforations of the colon, hollow viscous. So X-ray reveal pneumoperitoneum, and that management is the urgent laparotomy and bowel repair. So here the options is the left lobe of the liver. Now 27, IV drug user presented with swallowing in inguinal region with multiple past discharging sinuses. On investigation, psoas abscess was also diagnosed. What is the best treatment options here? So pass in incision and drainage is the first management of any abscess almost in anywhere. How we do it? Percutaneous CT guided drainage for deep collections. We can do the open if it is complex or multi-loculated abscess, then we have to do the open surgical drainage, then debridement of the necrotic tissue and wash out of the abscess cavity. Next, question number 28, first sight of hematopoiesis on the early embryonic period. Of course, the yolk sac. Yolk sac is the first one. Let's see summarizing the timing of this hematopoiesis is first weeks is started with the yolk sac from week 3 to 3-8. From week 6 till birth, liver and the spleen, and month 5 to lifelong is the bone marrow. So yolk sac is the first one, then the hepatic, and the final is the myeloid. Question 29. Young, stable patient with history of road traffic accident, chest X-ray shows hemothorax. What is the best management treatment? So it's a very clear-cut indications that is a trauma cases. The best possible do ICT tube, either 28 to 32. ICT tube given here, yes, chest intubations, intercostal drainage. Then this is the one. Yeah, this is the right answer here. What is the size? Chest tube size, ICT tube size, 28 to 32 FR. So what is the purpose? The drain accumulated blood and air from the pleural cavity and allow the lung to re-expansion, relieve respiratory symptoms, and definitely monitor the ongoing blood loss. Surgical intervention only needed if there is more than 1.5 liter, 1,500 liter more blood has been drained, then you have to open it. Keep that in mind. We give the ICT, and after the ICT, the blood collection within 24 hours is 1,500 liter or per hourly, more 200 ml per hour. If these two criteria meet, no ICT management now. We have to open it. We have to call the cardiothoracic surgeon. This is a very favorite question by the RCS. Keep that in mind. Okay. So this is under the ATLS protocol. This is the correct answer here. Next question. Question number 30. Open appendectomy done for acute pancreatitis. Patient presented with signs and symptoms of SSI, surgical site infection, and now organism involved. What is the most common? So the favorite uh, uh, microorganism for surgical exam or anywhere is Staph aureus. Clear-cut answer. So most common microorganism for SSI is Staph aureus. And keep that in mind. Particularly, it is very much important when there is a clean or clean contaminated wound, superficial or deep incised SSI, and early postoperative within 7 days is very much common. While appendicitis involve the gut flora, E. coli and bacteroids. Superficial wound infections following appendectomy are most commonly caused by the skin flora. So especially the Staph aureus introduced during the surgery, which makes the Staph aureus is a key target for perioperative prophylaxis. Cefazolin, injectable cefazolin is being given, and wound care protocol will be given. So anaerobic and or organism, why need to be the correct answer? E. coli or bacteroids. Let's say patient undergoes appendectomy for perforated appendicitis with diffuse peritonitis. Patient presented to us with diffuse peritonitis. Postoperatively, he develops persistent fever, abdominal pain. CT shows intra-abdominal abscess in the right paracolic gutter. Important. Intra-abdominal abscess in the right paracolic gutter. So percutaneous drainage has been done and foul-smelling pus. In that case, E. coli and bacteroids or gram-negative anaerobic organism is very much common. Polymicrobial gut flora typically involves. And a treatment requires, of course, give the broad spectrum antibiotic, piperacillin, tazobactam, meropenem. That's it.